Today, this is the 41st master class on behalf of ISHBT, Indian Society of Hematology and Blood Transfusion. And so since years, we are conducting this monthly master class mainly for students and for interactions and to learn together. So today we have an eminent speaker with us, Professor Rashmi Kushwaha. Rashmi Kushwaha is in charge of Hematopathology Unit, King George Medical University, Lucknow, and her area of specialization: immunopathies, lymphoma, leukemia, as well as coagulation disorders. And she is recently elected as our executive committee member of ISHBT. The topic of today's topic is diagnosis of disease. So we know that this is a disease, as far as bleeding disorder is concerned, the most confusing disease is von Willebrand disease because it can occur irrespective of gender, unlikely to hemophilia, and it can manifest even in the adulthood, and it can present across the different specialty, be it a gynecologist, be it a surgery, medicine. So there will be a talk and followed by question. So I welcome Professor Dr. Rashmi Kushwaha, and the stage is take over for your session.
Thank you so much, Dr. Rajiv, for the kind introduction. I'll just share my screen. Okay. So, is the screen visible to all?
Yeah, it is visible. Yeah.
Okay. Very good evening to all of you. So, this is the 41st masterclass of ISHBT. As all of you know that von Willebrand disease is one of the most common inherited bleeding disorder, and this is either due to deficiency of von Willebrand factor or due to functional abnormality in the von Willebrand factor. So these patients can present with an entire range of or a spectrum of symptoms, which could be either in the form of mild mucocutaneous bleeding to very severe hemorrhage. So the presentation is quite varied. The presentation age can also be varied. So it's a kind of complicated disease, and hence it becomes very important to understand this disease as well as the various diagnostic modalities and the various recommendations or the guidelines that have been laid down for the diagnosis of this disease. So this entire PowerPoint presentation or the class is based on the diagnosis of the von Willebrand disease along with the recent guidelines and the recommendations for the diagnosis. Von Willebrand factor gene is located on chromosome 16. So von Willebrand factor is synthesized in the endothelial cells and in the megakaryocytes. So as you can make out, this is a monomer of von Willebrand factor. This monomer consists of various domains. Here we have a propeptide, a D1 and D2 domain. And just a second, I'll just on the pointer. Yes. So D1 and D2 has a propeptide domain. The factor 8 binding site is a D3 domain. The A1 and A3 has collagen binding domain with specifically type 1 and type 3 collagen binding domain at A3, and glycoprotein 1b alpha receptor on the platelet has a binding site with A1 domain. The ADAM-TS acts at the A2 domain. The function of the ADAM-TS is to excise the ultra-large multimers of the von Willebrand factor so that it prevents the uncontrolled thrombosis in the body. And the glycoprotein 2b3a binding site is at C1 and C2. So once these monomers are synthesized in the cells, it undergoes binding with each other through the disulfide bond, forming the dimers, and these dimers further bind with each other to form the multimers. So inside the cell, when these multimers are synthesized, they are bounded with the propeptide. This propeptides helps in the intracellular transportation of the von Willebrand factor. But once this von Willebrand factor is released into the circulation, this propeptide is excised off and then it is released into the circulation. So coming to the function of the von Willebrand factor, let's understand from this diagram, whenever there is any injury to the vessel wall, this causes the exposure of the subendothelial collagen. So the von Willebrand factor comes to the site of injury, and with the help of the collagen binding domain, it binds to the collagen, as well as it binds to the platelets from glycoprotein 1B receptors on the platelet. So once the platelets are bound here, they will activate the other platelets and causing the release of the various factors and formation of the platelet plug. So this is how the von Willebrand factor plays a role in the primary hemostasis. It has another role in the plasma. It acts as a carrier molecule for the factor 8 or the chaperone for the factor 8. So factor 8 is bound to von Willebrand factor in the circulation. So this will prevent the proteolytic digestion of the factor 8 and it enhances the half-life of the factor 8. So it will recruit the factor 8 to the site of injury where the platelet plug was there. So factor 8 will now act on the surface of the platelets to activate the secondary pathway of coagulation. Hence, the von Willebrand factor plays a role in the primary hemostasis as well as in the secondary hemostasis. Hence, the patient can present with symptoms of mild mucocutaneous bleeding or could be can present with deep bleeding or the severe hemorrhage also. So, von Willebrand disease follows the Mendelian genetics. It is autosomal inheritance in nature, with type 1 and type 2 being the autosomal dominant and type 3 being the autosomal recessive. Here, the males and females are both equally affected. However, if a person is having the mutation, it's not necessary that that person will express the symptoms. So, this phenomenon is called as incomplete penetrance. And at the same time, in a family, if two or three people are having this von Willebrand factor gene in them, it's not necessary that all of them will have a same pattern of disease. Some can have a mild bleeding tendency and some can have a severe bleeding tendency, and this is called as the variable expressivity. Now, the von Willebrand disease is broadly classified into three types. First, it is the one is because of the quantitative deficiency where the von Willebrand factor protein itself is deficient, and second one is due to the qualitative abnormalities where although the factor is present but it is not able to function properly. So in the quantitative deficiency we have type 1 or the partial quantitative deficiency of von Willebrand factor. This accounts for 70% cases of all 70% of all the cases of von Willebrand disease. And here the patient usually has mild to moderate disease with autosomal dominant inheritance pattern. There is a newer entity which is called as the type 1C. Type 1C is characterized by increase in von Willebrand factor clearance from the circulation. Another type of quantitative deficiency, this is called as type 3 von Willebrand disease. Here the patient has total or near total quantitative deficiency of von Willebrand factor. This patient, because it's almost complete deficiency of VWF, so these patients usually have a severe disease and they present with severe bleeding symptoms, and this accounts for 5% of the cases of all the von Willebrand disease patients. It is autosomal recessive in inheritance. Coming to the qualitative defects or the type 2 von Willebrand disease, here we further subcategorize them into type 2A, 2B, 2M, and 2N. 2A is characterized by reduction of high molecular weight multimers. Type 2B is characterized by, even in type 2B, there is loss of very high molecular weight multimers. Along with this has a gain of function mutation where the von Willebrand factor has increased affinity for platelet glycoprotein 1B. So what happens that von Willebrand factor binds, it has more affinity and it binds to the platelet glycoprotein 1B and it causes the agglutination with platelets leading to the removal of these agglutinates from the plasma, and so hence these patients can present with mild thrombocytopenia. Type 2M is characterized by reduced interaction of von Willebrand factor with platelets as well as with the collagen. And type 2N, as I told you in the beginning, the von Willebrand factor acts as a chaperone for factor 8 and it binds to factor 8 and carries it in the plasma. So what happens in type 2N? There is reduced binding of von Willebrand factor to factor 8. Hence, there is loss of factor 8 from the plasma, leading to the deficiency of factor 8. So the patients with type 2N can present with symptoms very similar to the hemophilia A. Now coming to the symptoms, these patients present with the entire spectrum of bleeding symptoms, which could be in the form of mild mucocutaneous bleedings like easy bruising, frequent epistaxis, prolonged bleeding from injuries, gum bleeding. Could be in the form of the post-surgical bleeding whenever a patient is faced with any kind of challenge. In females usually present with menorrhagia, with this symptom being one of the most common symptom seen in the females, or they can present with the postpartum hemorrhage. In cases of severe deficiency, patients can present with joint and muscle bleeding. They can have the internal bleeding as well as the spontaneous bleeding. So, whenever we get a patient in the coagulation lab for the diagnosis of a bleeding disorder, we start with the history taking. And a good history is must for the diagnosis of the bleeding disorder. For this, the bleeding assessment tool, which is given by the ISTH SSC. So, this BAT score or the BAT bleeding assessment tool is quite handy. And in fact, we can take a printout of this bleeding assessment tool and keep it in our laboratories and train our residents to take the history as per the this bleeding assessment tool. So I'll just show you. This is what it consists of. It has various symptoms on one side like epistaxis, cutaneous bleeding from minor wounds, oral cavity bleeding, GI cavity bleeding, menorrhagia, postpartum hemorrhage. And on the other side, it has the severity of this bleeding as well as the treatment required to stop the bleeding. So, depending on the history, we give a score to each of the bleeding symptom, and towards the end, we add up all the score. So, a score of more than or equal to 4 in men, more than or equal to 6 in women, and more than or equal to 3 in children is considered to be abnormal, and this score is considered to be significant. And these patients, if the score is more than these patients are supposed to be true bleeders, and they need further evaluation for the diagnosis of the bleeding disorder. In 2021, the American Society of Hematology, International Society of Thrombosis and Hemostasis, National Hemophilia Foundation, and World Federation of Hemophilia came together and they laid down these guidelines for the diagnosis of von Willebrand disease. So, along with the lab investigation, I will be discussing these guidelines also. So the first three guidelines are about the history taking and how to suspect von Willebrand disease and what to do when we are taking the history right at the beginning. So recommendation one says that it is basically for the patients who can have the low probability of von Willebrand disease. These are those patients who come to the clinic or to the PHC CHCs with the symptoms of mild bleeding episodes. However, they don't have any family history, they don't have any previous history of bleeding. So as per the recommendation, they say that we can use a bleeding assessment tool, and if the patient has a positive BAT score of more than the recommended value, we can go ahead with the further screening as well as the diagnostic test. Recommendation 2 is for the patients with intermediate probability of von Willebrand disease. Now, who are these patients who come into this category? These are those patients who have an abnormal bleeding history in the past or an abnormal initial lab test. So, if any patient falls into this category, it is recommended not to rely on the BAT score only, but instead BAT score should
Yeah,
be used in conjunction with the other specific
7:15.
blood test for the diagnosis of von Willebrand disease.
Got
Coming to
it.
the recommendation 3 is for the patients who have a very high probability of von Willebrand disease. Now, these are the patients who have the affected first degree relative, regardless of the bleeding symptom or the initial test. So, if the patient is having the affected first degree relative, it is recommended to use the BAT score in conjunction with the other specific tests for the diagnosis of the von Willebrand disease. Now, after the good history taking, we proceed ahead with the sample collection. So, for the sample collection, we have to take care of the pre-analytical variables that can affect our result. So von Willebrand factor levels may be elevated during any kind of stress, exercise, or post-operatively in case of any kind of inflammation and during pregnancy. Hence, it is recommended to do von Willebrand disease at the baseline health level when these factors will not affect the von Willebrand factor quantity in the blood. Because if we are taking blood with in any of these conditions, then there will be some elevation of von Willebrand factor, and there will be you can say we can get the false negative result, or the cases of mild von Willebrand disease can be missed out. So always collect the sample at the baseline health level after excluding all these inflammatory conditions or certain physiological conditions. And it is recommended to collect the sample on two separate occasions. Like all the coagulation tests, the sample is collected into the 3.2% sodium citrate in 1:9 ratio. And usually, for all the bleeding disorder, we prefer to collect the blood ourselves in the laboratory. But at times, in certain situations, when the patient is not able to come, we might have to instruct the sisters or the our residents to send the sample from the wards and the ICUs. In such situations, after collecting the sample must be transferred at the room temperature between 18 to 25 degrees centigrade. This sample must not be frozen after collection and must not be transferred in the ice, because transferring in the dry ice or freezing the sample will lead to precipitation of von Willebrand factor and factor 8. So this precipitation, it undergoes precipitation as well as time dependent reduction of von Willebrand factor and factor 8. So it is ideal to transfer the sample at room temperature, and further processing should also be done at the room temperature. So whenever we collect the sample, our target is to uh, finish off all the testing within 12 hours. So after the sample is collected, we proceed ahead by separation of the plasma at the standard rotations at the standard time. And after the collection of the plasma, one has to take care that the testing is finished within 4 hours. Because if we keep this plasma for a long time, then the factor 8 reduces by up to 14.8% in 4 hours. So better to finish off the test within 4 hours of separation of the plasma and within 12 hours of collection of the blood sample. But just in case, if we are not able to do the test within the recommended time, it is better to freeze the plasma at minus 70 degrees centigrade or minus 24 degrees centigrade. Now, here again, one has to be very careful. Once we have frozen the plasma, and later on, whenever we are planning to do the test, we have to thaw the sample. Now, this thawing of the sample must not be done at the room temperature, because it will cause a precipitation of von Willebrand factor and factor 8. Thawing is to be done in the water bath at 37 degrees centigrade. So, these are certain precautions we have to take while collecting the sample as well as while transporting the sample to the laboratory. Now, coming to the initial laboratory screening, like any bleeding disorder, when we are evaluating, we'll start with the basic screening tests, so which are mandatory for the coagulation workup. Now, coming to the bleeding time, bleeding time is a test which depends to a lot extent on how accurately it has been done. Like if you are having a proper lancet which has a proper depth and the proper width, and if the technique is proper, then it will give the reliable result. However, if not done properly, it can mislead. So bleeding time must be performed with utmost caution. Patients with von Willebrand disease can have a prolonged bleeding time and can have a normal bleeding time also. So a normal bleeding time will not rule out von Willebrand disease. The next is CBC and platelet count. CBC is done routinely for all the cases that we get, to give an idea about the platelet count. And if you want to appreciate the platelet morphology and the platelet clump, it is advisable to make a fresh smear. Don't make the smear from the EDTA blood. Always make a fresh smear while collecting the sample from the patient, to appreciate for the platelet clump and the platelet morphology, because EDTA can itself lead to changes in the platelet morphology as well as disintegration of the platelet clump. Next is activated partial thromboplastin time. APTT can be prolonged because of secondary deficiency of factor 8 due to deficient von Willebrand factor. But again, all the cases of von Willebrand disease do not have a prolonged APTT, and at times many cases have a normal APTT. So a normal APTT again will not rule out von Willebrand disease. The other optional tests are prothrombin time, fibrinogen, and thrombin time. Although these tests will not contribute to the diagnosis of von Willebrand disease, but still we do the entire battery of the laboratory initial screening test to rule out a disorder other than or in addition to the von Willebrand disease. So once we are done with the laboratory screening test, we proceed ahead with the specific test for the von Willebrand disease. Here we have von Willebrand factor antigen level. It measures the level of VWF protein, factor 8 level, ristocetin cofactor level, or other platelet dependent von Willebrand factor activity tests like glycoprotein 1bm and glycoprotein 1br. Now it is mandatory to perform minimum 3 or if possible more than 3 different tests as a minimal laboratory panel before VWD can be effectively diagnosed or excluded. The other tests which can be done are the collagen binding assay, factor 8 binding assay, ristocetin induced platelet aggregation, multimer assay, and the genetic testing. So I'll go one by one through each of them now. So von Willebrand factor antigen, this is basically a immunological assay. It can be done based on the ELISA technique or it can be done in a fully automated equipment using the immunoturbidometric method. So this antigen level correlates directly with the concentration of the von Willebrand factor in the plasma. So normally it is in the range of 50 to 200 international unit per deciliter. So type 1 von Willebrand disease can have mild to moderate reduction of von Willebrand factor antigen, whereas type 3 there is almost complete absence of the von Willebrand factor antigen. However, type 2 von Willebrand disease, because type 2 is not the quantitative reduction, type 2 is the qualitative abnormality. So type 2 can have a normal or reduced antigen. Hence, von Willebrand factor antigen levels alone cannot be used for the diagnosis of von Willebrand disease and it must be combined with other investigations. So the other test is factor 8 level. Now, since von Willebrand factor acts as a carrier molecule for factor 8, so any reduction in VWF will cause a corresponding reduction in the factor 8. So it is assumed that it is that factor 8 will be reduced. However, in certain mild type of von Willebrand disease like mild type 1 or in some patients with type 2B and 2M von Willebrand disease, the factor 8 level may be normal. Whereas in type 3 von Willebrand disease, there will be marked reduction in factor 8 level. And in type 2 and von Willebrand disease, again factor 8 will be markedly reduced because there is defective binding of von Willebrand factor with the factor 8. Coming to the platelet binding assays, here we have 3 tests: von Willebrand factor ristocetin cofactor binding assay, glycoprotein 1br binding assay, and the glycoprotein 1bm binding assay. So coming to the ristocetin cofactor activity, now ristocetin is an antibiotic. Whenever it is added to the plasma, it causes the conformational change in the von Willebrand factor, which leads to binding of VWF to the platelets. Now, this increased platelet agglutination is detected in this test, and normal ristocetin cofactor activity is between 50 to 200 international unit per deciliter. However, with most of the reagents available, the lower limit of quantification is between 3 to 10. Hence, in cases of severe type 1 or severe type 2 von Willebrand disease, it will not be possible to differentiate it from type 3 because in severe type 1 and type 2, the ristocetin cofactor activity will be markedly reduced, and same thing happens in type 3. The other platelet binding assays are glycoprotein 1br. It is based on the latex agglutination or chemiluminescence technique. Here the platelets are replaced with the latex or the magnetic particles, and the native glycoprotein 1b, which is present on the platelet, it is replaced with the recombinant glycoprotein 1b, and which attaches to the latex or the magnetic particles upon addition of the ristocetin. However, this technique is less well established, less accessible, and more expensive. Similarly, the glycoprotein 1bm assay, it is again latex agglutination by ELISA. However, this technique is not ristocetin based. Here the platelets are replaced with the latex, and glycoprotein 1b receptor on the platelets is replaced by gain of function or the mutated recombinant glycoprotein 1bm. This test again has a drawback that in patients of type 2B von Willebrand disease who have gain of function mutation can give falsely high values. So both glycoprotein 1BR and 1BM are less well established techniques. They are less accessible and more expensive. However, as per the guidelines, the recommendation 4 that were mentioned in the guidelines, it is said that it is preferable to use the glycoprotein 1BM and 1BR over the one factor ristocetin cofactor assay if these techniques are available in the laboratory. Now coming to the next test, that is one factor collagen binding assay. It tests the ability of one factor to bind to collagen. And as I showed in the initial slides, that collagen binding sites are present in domain A1 and A3 of the monomer. Collagen binding activity depends on the multimer size. That means the large multimers would be able to bind um, uh, more effectively with the collagen. Hence, the patients with type 1 von Willebrand disease, type 2A, type 2B, and type 3 will have defective collagen binding. Why is this so? That patients with type 2A have loss of high and intermediate molecular weight multimers. So, collagen binding will be abnormal. Similarly, in type 2B, there is gain of function mutation, but at the same time, there is loss of very high molecular weight multimers. So, collagen binding will be affected. In type 3 von Willebrand disease, there is in type 1 and type 3, which were the quantitative abnormalities causing the reduction of von Willebrand factor. So, although the multimers are normal in size, but there is overall reduction of the factor leading to overall reduction of the multimers. Hence, in all these types, the collagen binding will be affected, whereas the collagen binding assays will be normal in type 2M and type 2N because these two conditions did not lead to any abnormalities in the multimer. The next test is ristocetin induced platelet aggregation. This is a qualitative test, and here we check for the agglutination of platelets in response to the ristocetin. So there will be decreased aggregation with ristocetin in von Willebrand disease and in Bernard-Soulier patient. Now, just to show the aggregation curve from our lab, now this is the normal aggregation pattern, and as we can make out, the blue curve is with the ristocetin at the standard dose of 1.75 milligram per ml, and we can see a good aggregation response. And the maroon curve is with the ADP at the standard dose. Again, a normal aggregation response is seen. This is a normal aggregation curve. Now, let's see what has happened here. Here with the okay, here with the ADP, we are seeing a normal aggregation curve, and with the ristocetin at the standard dose, there's almost total absence. There's total absence of the aggregation. So there was no aggregation with the ristocetin. So this could be either von Willebrand disease or could be Bernard-Soulier based on the platelet aggregation studies. To differentiate between these two conditions, we proceed ahead with the mixing studies in the aggregation. So how this is done? We take the platelet-rich plasma of the patient and mix it with the control plasma. Since the patient was deficient in one Willebrand factor and the control plasma will have one Willebrand factor, so once we mix it, the sample will have VWF from the control plasma. And when we repeat the aggregation using this, we'll get the normal aggregation response with the mixing studies. So this suggests that this patient has a von Willebrand disease, which could be confirmed by other techniques as well, whereas this correction will not be seen in the Bernard-Soulier. In Bernard-Soulier, it is other way around. By mixing with the control plasma, there will be no correction. However, if we mix the patient plasma with the control platelets, then we can see the correction of the aggregation studies. Now, we can further proceed ahead in the aggregation studies using the low dose ristocetin. So, the ristocetin can be titrated lower down up to 0.5 milligram per ml. And patients of type 2B von Willebrand disease who had gain of function mutation or increased binding capacity of BWF to the glycoprotein 1B on the platelets. So, these patients will show these patients will show aggregation even at the lower dose of the ristocetin of 0.5 milligram per ml. Not only type 2B von Willebrand disease, even that pseudoplatelet type von Willebrand disease, there also patient will have hyperaggravailability with the low dose of ristocetin. Coming to the von Willebrand factor binding to factor 8. Now, in type 2 and von Willebrand disease, there is defective binding of VWF to factor 8. Hence, these patients will have a very low factor 8 level. So, factor 8 to antigen ratio will be reduced. To further confirm the type 2 and von Willebrand disease, we can proceed ahead with the genetic analysis. And to differentiate from the hemophilia, we can further do the genetic analysis for hemophilia. These are the certain assay ratios depending on the test that we just discussed. Here we have ristocetin cofactor to antigen and the platelet binding assay to the antigen ratio. In type 1 von Willebrand disease, since antigen levels were reduced, activity level was also correspondingly reduced. So the ratio will be around unity or more than 0.7. However, in type 2 von Willebrand disease, because the functional capacity is more reduced when compared to the antigen level, this ratio will be less than 1 or less than unity. Similarly, the collagen binding to antigen ratio, again here in type 1 and type 2 and von Willebrand disease, it will be more than 0.7 and it will be further reduced in type 2A, 2B and 2M type of von Willebrand disease because these 2A and 2B have defective multimers leading to reduction in the collagen binding capacity and this ratio will be less than 0.7. Now coming to the factor 8 to antigen ratio, this will be markedly reduced in type 2N because type 2N has defective factor 8 binding with the von Willebrand factor. So these ratios help in diagnosis of and further subcategorization of various type of von Willebrand disease. Coming to the multimer analysis, it is a method for analyzing the concentration and distribution of von Willebrand factor multimers present in the plasma. It is done using the agarose gel in the presence of SDS. So this is a diagrammatic representation, and as you can make out in this, this is the normal plasma showing the normal multimers, whereas this is type 1 von Willebrand disease. Now, type 1 von Willebrand disease has reduced amount of antigen, hence all the multimers will be correspondingly reduced, but they are present. What happens in type 2A? There is selective loss of large and intermediate multimers of the von Willebrand factor. In type 2B, there is loss of the large multimers of the von Willebrand factor. And in type 3, which is characterized by almost total absence of von Willebrand factor antigen, we can see there are no multimers present. Now, von Willebrand factor propeptide, how is it helpful? So, as mentioned in the beginning of the presentation, the von Willebrand factor, once being synthesized inside the cell, it is bound to this propeptide, which helps in the intracellular transportation of the von Willebrand factor. But before release into the plasma, the propeptide is cleaved off. So, if we can measure the propeptide to antigen ratio to identify those individuals who have increased clearance of antigen from the like type 1C von Willebrand disease, which are characterized by increased clearance of von Willebrand factor from the circulation. So these patients have uh, maintained propeptide level, however, antigen is markedly reduced. So this ratio will be more than unity. Coming to the recommendation 5, which was laid down in the guidelines that I am discussing. Here, what happens that suppose a patient is diagnosed to have type 1 von Willebrand disease, but now von Willebrand factor has a tendency that with any associated comorbidities or with aging of the patient, the von Willebrand factor can come to a normal level, especially those patients who were diagnosed to have a mild type of von Willebrand disease. Now, with aging and with associated inflammatory conditions or comorbidities, the patient has a normal von Willebrand factor now. So what do you do? Do you still label them as a patient of von Willebrand disease, or you remove this label of VWD from them and tell them that okay, now you don't have the disease, you are normal. So this recommendation is for these kind of patients. And as per the guidelines, it is said that it is better not to remove the level of not to remove that label of von Willebrand disease from these patients because although VWF level has come to normal in these patients, but probably further down during any time period, they can present with severe bleeding when exposed to any kind of stress. Hence, it is still better to consider them as the patients of type 1 von Willebrand disease. Coming to the recommendation 6. Now, recommendation 6 is for the confirmation of type 1 von Willebrand disease. So, here the panel recommends that VWF level of less than 30 international unit per deciliter regardless of the bleeding symptom. If the patient is having value less than 30 international unit per deciliter, they must be labeled as von Willebrand disease patient. But if the value is between 30 to 50 international unit per deciliter, and if the patient has associated bleeding history, we will label them as von VWD patient. But if the patient has values between 30 to 50 international unit per deciliter, but there is no bleeding history in these patients, we do not call them as VWD patient. Instead, we keep them into the category of low VWF as a risk factor for bleeding. And we will not call them as VWD status. So I hope this concept is clear that any value less than 30 international unit per deciliter, regardless of the bleeding symptom, these patients will be called as VWD patient. Between 30 to 50 international unit per deciliter, with the presence of the bleeding history, they will be called as VWD patient. However, if the patient has no bleeding history, we'll just label them as low von Willebrand factor as a risk factor for bleeding, and they will not be categorized into the VWD disease status. Recommendation 7 is for type 1C von Willebrand disease. 1C is characterized by increased clearance of VWF from the circulation. So, as I mentioned, the propeptide to antigen ratio will be more than unity because propeptide is still maintained in the plasma, whereas the antigen is being lost. However, the recommendations say that we can use an alternative test, that is desmopressin trial, and this alternative test is preferred over this ratio. Now, what the desmopressin does is that once it is given to the patient, it causes the release of VWF into the circulation. However, in these patients of type 1C, there is increased clearance of VWF. So, once we measure at 1 hour the level of one brain factor antigen, then we again measure at 4 hour. If there is a reduction of more than 30% of the VWF level in these patients, it suggests the diagnosis of type 1C VWD. So, as per recommendation 7, desmopressin trial is preferred over peptide to antigen ratio. Now, recommendation 8 is for the type 2 von Willebrand disease. Here, the panel says that activity to antigen. So, here the debate was, or I mean, the consideration was whether to keep the cutoff of activity to antigen ratio to 0.5 or to 0.7. So, the panel said that it is better to keep the cutoff ratio to less than 0.7 to confirm the diagnosis of type 2 von Willebrand disease. Because if we keep the cutoff very low, then probably we are going to miss out those patients who have very mild type of von Willebrand disease. So, it is better to keep the cutoff slightly high to prevent the false negatives. This is the algorithm based on the recommendations that we just discussed. So any patient presenting with a bleeding history, any patient presenting with the bleeding history or suspected of VWD, we start with the history taking with the help of the bleeding assessment tool. If the bleeding assessment tool is negative, then it almost rule out one brain disease in category 1 patient, that is those patients who never had any past history of bleeding and who don't have any first degree relative with a bleeding symptom. However, if even if in certain patients, in as mentioned in the recommendation 2 and 3, those patients who have a past history of bleeding, or those patients who have a first degree relative who has a bleeding disorder, then we have to further proceed ahead with the screening test. Similarly, if the bleeding assessment tool is positive, then again we'll proceed ahead with the screening test that I just mentioned. So, irrespective of the screening test, whether positive or negative, because as mentioned, the bleeding time, the APTT, these things can come out to be normal in VWD patients many a times. So, irrespective of the results of the screening test, we proceed ahead with the confirmatory test. Here we do antigen level, factor 8 level, and the platelet dependent von Willebrand factor activity. Now, if the antigen level is more than 50 international unit per deciliter, it rules out von Willebrand disease. However, if the antigen level is between 30 to 50 and the patient do not have any bleeding symptom, then as mentioned earlier, these patients will be kept into a separate category of low von Willebrand factor at a risk of bleeding. However, they will not be labeled as a patient of VWD. Now, but if the antigen level is between 30 to 50 international unit per deciliter and the patient has the bleeding symptoms, we proceed ahead with the other test. Similarly, if the VWF level is less than 30 international unit per deciliter, we proceed ahead with the activity to antigen ratio. Now, if activity to antigen ratio is more than 0.7, it is type 1 von Willebrand disease. And in type 1, to differentiate or to further subcategorize type 1C, we do the desmopressin trial. If desmopressin trial is positive, we call it as type 1C von Willebrand disease. If the activity to antigen ratio is less than 0.7, it suggests type 2. That means less than 0.7 means the activity is more severely affected. So it points out to type 2 von Willebrand disease. We further do the collagen binding to antigen ratio or the multimer analysis. If the multimer analysis or the collagen binding to antigen ratio is abnormal, it points to type 2A or type 2 von Willebrand disease, and this is further confirmed using the genetic testing. However, if the multimer analysis is normal, it points towards type 2M von Willebrand disease. Now let's see what was happening here. Now to confirm type 2 and von Willebrand disease, we check for the von Willebrand factor to factor 8 ratio. In type 2 and factor 8 will be, it is like there is defective binding of VWF to factor 8. So there is increased clearance of factor 8 from the circulation leading to markedly reduced factor 8. So if you are suspecting type 2 and it is confirmed by the genetic testing. Coming to the recommendation 9. So this is for patients of type 2A, 2B or 2M who are in need of additional testing. Here the panel suggests that we can use either multimer analysis for the diagnosis of 2A, 2B because both have abnormal multimers, or we can use the collagen binding to antigen ratio. Since the collagen binding uses type 1 or type 3 collagen, it can be used as a surrogate for the presence of high molecular weight multimers. So we can use either of these tests to diagnose type 2A, 2B and to differentiate it from type 2M because 2M is going to have a normal multimer analysis or normal collagen binding to antigen ratio. Recommendation 10 is for the patients like it's for the patients for type 2B von Willebrand disease who have low dose ristocytin induced platelet aggregation. So as per the recommendation 10, what actually was discussed in that article is that if we are suspecting patient to have type 2B von Willebrand disease, either we can proceed ahead with the ristocytin induced platelet aggregation or we can proceed ahead with the genetic testing. But since the aggregation facilities are not available at all the center, one point is that all the centers don't have the aggregation facility. Second thing is that whenever we are planning the aggregation studies, it should be done within 4 hours of collection. Now, if we want to transfer the sample to another center for aggregation studies, that is definitely going to take more than 4 hours to transfer it to any nearby center. So the genetic testing was kept at an upper level when compared to the ristocytin induced platelet aggregation. Agreed, all the centers don't have the facility for genetic testing also, and even for the genetic testing, we need to transfer the sample to the next nearest center which has the facility. But this time boundation is not there for the genetic testing, which is there for the ristocytin induced platelet aggregation. So if the genetic testing is positive for 2B, then it confirms the diagnosis of 2B. If we are proceeding ahead with the ristocytin induced platelet aggregation, if the platelet aggregation is with ristocytin is absent, it points towards diagnosis of type 2A von Willebrand disease. However, if there is ristocytin induced platelet aggregation there is normal aggregation with ristocytin, it shows that it could be other subtypes of von Willebrand disease or could be because of the other bleeding disorder. And of course, if we have the aggregation facility, we can further proceed ahead by doing the low dose ristocytin aggregation studies for type 2B von Willebrand disease. Recommendation 11 is for the patients who are suspected to have type 2N. So type 2N has defective binding of factor 8 with von Willebrand factor leading to increased clearance of factor 8 from the circulation. So either we can do VWF to factor 8 binding assay, which will be abnormal in these patients, or we can directly proceed ahead with the genetic testing for factor 8 and VWF gene. with the major differential being the hemophilia A. Now, if the patient is suspected of type 2 and von Willebrand disease, so either we can proceed ahead with the VWF to 8 binding assay, or we can proceed with the genetic testing. So, because this is like more easily available, von Willebrand factor to factor 8 binding assay, if this is normal, then it will rule out 2 and von Willebrand disease, and we further proceed ahead with factor 8 level. If factor 8 level is normal, then consider other subtypes of VWD. However, if the factor 8 level is abnormal, it points towards hemophilia A and further workup is required. If this VWF to factor 8 binding assay is abnormal, that means it points towards type 2N, and further we can proceed ahead for confirmation with the genetic studies. If it's positive, it diagnoses the type 2N von Willebrand disease. Now, this chart is to summarize the various types of von Willebrand disease and the various tests that can be done. So, when it comes to the antigen, type 1 VWD has reduced antigen, type 3 is almost absent antigen, whereas the antigen can be reduced or can be normal to reduced in other types of type 2 von Willebrand disease. Similarly, ristocytin cofactor activity is reduced in type 1, almost absent in type 3, markedly reduced in type 2A, where there is loss of high and intermediate molecular weight multimers, reduced in type 2B, and markedly reduced in type 2M. Factor 8 level has a corresponding reduction as that of antigen level. Ristocytin induced platelet aggregation is almost absent in type 3, and we see increased aggregation in type 2B at a very low dose ristocytin. So low dose ristocytin aggregation is seen with type 2B von Willebrand disease. Bleeding time is not very reliable because it can be normal in patients of von Willebrand disease, and desmopressin will give a positive result with type 2 and von Willebrand disease. Now coming to the multimer, so in type 1 von Willebrand disease, because antigen is less, although the multimers are normal, but they will be reduced in quantity. Whereas in type 3, it will be absent. Type 2 is characterized by loss of high and intermediate molecular weight multimers. Type 2 is characterized by loss of high molecular weight multimers, and these multimers will be normal or slightly reduced in type 2M and type 2N von Willebrand disease. So, with this entire presentation, the take home message is that whenever a patient comes for evaluation of the von Willebrand disease, always start with a good history taking. As far as possible, collect the sample in the lab itself. And if at all we are not able to collect the sample in the lab and we are getting the sample from the wards or from the ICUs, we have to instruct the residents and the nurses on how to send the sample to the laboratory, perform the test within the recommended time. If you're not able to perform in the recommended time, store the sample as per the guidelines at -20 or -70 degrees centigrade, and then whenever you are planning to do, you can thaw the sample in the water bath. Minimum 3 tests are required, that is antigen level, activity level, and factor 8 level. But to further subcategorize, we need the help of the other tests like collagen binding assay and the other tests which I just mentioned, propeptide to antigen ratio and the factor 8 binding activity. And the various ratios which I discussed are quite helpful in further subcategorization of these tests. So, these are the references for this presentation. Thanks a lot. The house is open for the question now. Any questions are invited. I cannot see any questions in the chat box. So if anybody has any queries, you can ask me. Sir, good evening. Sir, good evening.
Good evening.
Okay, I got a question. What is the cutoff for platelet count to perform this testing? So if you are talking about the platelet aggregation studies, then Ideally, aggregation studies, if you're separating the platelet-rich plasma, then the platelet count must be more than 1.2 to 1.5 lakh to perform the aggregation studies. However, in even if like instead of making the PRP, if you are using the whole blood, then the platelet aggregation studies can be performed up to the platelet count of like if the platelet count is above 50,000. So it depends if you are using the PRP or the whole blood to perform the platelet aggregation studies. Any further questions? Any further questions from the participants?
Uh, Congratulations, Dr. Rashmi. Hello.
Thank you, sir.
Hello.
Yes,
It was very good presentation, and
thank you, sir.
especially for postgraduates. Just for
Thank
the
you.
sake of you know making an awareness, uh, because in our setup we don't have all the facilities for complete diagnosis of Van Willebrand's. Is it possible for us to get some indirect hints? For example, type 2B, any puberty menorrhagia girl having prolonged APTT and thrombocytopenia, can we uh, conclude as type 2B?
Yeah, like if females usually present with menorrhagia, and von Willebrand disease is one of the most common causes of menorrhagia. However, if specifically to diagnose type 2B, I think the low dose platelet aggregation studies with ristocetin is required, and the APTT can be normal in mild types of von Willebrand disease, so it will not give much of the clue. It's not always necessary that APTT will be prolonged.
Hmm. Hmm. No, with just thrombocytopenia in a puberty menorrhagia with
Yes,
prolonged APTT,
yes,
obviously.
I feel it can be a hint because patients of type 2B von Willebrand disease usually present with mild thrombocytopenia, but again we have to rule out like thrombocytopenia due to some other cause itself can lead to menorrhagia. So all
Hmm.
those causes of thrombocytopenia needs to be ruled out in such cases.
Okay. And another challenging thing we generally face is to differentiate from hemophilia A,
Yes. So
especially, yeah.
yes. So, first of all, is the pattern of inheritance. Like a female presenting with menorrhagia is more likely to be VWD and not hemophilia. And usually, patients of hemophilia have deep bleeds, muscle bleed, the joint bleeds. Whereas patients with von Willebrand disease can have entire spectrum ranging from mild mucocutaneous bleeding to epistaxis, gum bleeding, and um, patients with severe VWD can present with deep joint bleeding or the intramuscular bleeding. So there is an entire range of bleeding symptoms in VWD.
Yeah. And one more message we need to give is whenever Van Willebrand disease has to be must be differentiated from mild to moderate hemophilia A because of the treatment with high purity anti-hemophilic factors,
Mhm.
which doesn't
Yes.
contain Van Willebrand.
Yes, this is a very good point, sir. Like, if we are diagnosing any patient with hemophilia A, we have to rule out von Willebrand disease because, as mentioned, VWF acts as a carrier molecule for factor 8. So, factor 8 deficiency could be because of VWD. So, it's
Yeah.
always recommended to rule out von Willebrand disease before giving a diagnosis of hemophilia.
Yeah, because earlier it was not a problem because the crude AHF no used to contain
Yes,
both factor 8 as well as van Willebrand factor. But nowadays, because of the purification process products undergo, no, so van
yes.
Willebrand factor will be destroyed in during purification.
Yes, sir. So this is a very important point, and in fact, this should be conveyed to all the residents who are listening that when we are diagnosing hemophilia A, always rule out von Willebrand disease. in these patients.
Thank you, Rashmi. We are very happy and congratulations once again for your lucid presentation.
Thank you, sir. Dr. Simi is asking, is there any entity acquired von Willebrand disease similar to acquired APS? Yes, definitely there is an entity of acquired von Willebrand disease, and it can be seen secondary to certain conditions like any kind of malignancies or lymphomas, or secondary to rheumatoid arthritis, etc. So always, even the acquired von Willebrand disease has to be kept in mind when diagnosing these conditions. Okay, Vidyut sir is asking, is it like that increase in VWD factor in infection might be related to raised platelet count as seen? Okay, von Willebrand factor as such will be increased in any kind of inflammatory conditions and in infections. However, I don't know like if there is any correlation between the increased VWF with increased platelet count as seen in the infection. So one more question by Dr. Srinadhana. Bleeding history present, but PT, APTT, TT, and antigen values are normal. What else would you recommend in the resource poor setting? Okay. So as I said, the initial screen test can be normal in type 2 von Willebrand disease and the mild forms of von Willebrand disease. But I feel these cases need further workup to further subcategorize. Like we have to proceed ahead with the antigen levels. Okay, if the antigen level is normal, then definitely this could be a type of type 2 von Willebrand disease which has a functional abnormality, and you can proceed ahead by doing the various assays, like you can proceed ahead by doing the aggregation studies or the other ristosinin cofactor activity or collagen binding assay, uh, as mentioned. And further, I mean, this it's very like it's questionable if all these facilities are available at the resource poor setting, because many of the laboratories don't have the platelet aggregometers as well as don't have the facility for the ristositine cofactor activity as well as the collagen binding assays. So this point is really like it's questionable. Yes. If there are any further questions, it can be asked.
Ma'am, there is one more question in chat box.
I think all the questions have been answered by ma'am. So, ma'am, can we close the class for today?
Yeah, I can see one question: role of rotum or elastography in von Willebrand disease. So I don't know how far the rotum is going to help for the diagnosis of von Willebrand disease, and probably like we can go through this topic. And for any other questions are there? If it's there, I can take up the questions. Yeah, one question: can von Willebrand disease be suspected in neonates? Yeah, the neonates as well as the pediatric population have a entire different, you can say a different normal range of the various factors. So even neonates can present with the von Willebrand disease, and the workup is the same as recommended. However, the antigen values as well as the other values will be slightly different in the neonates. So we have to consider the neonates or the pediatric age group as per the normal values for that age group. Any other questions? If there are no questions, then I think I can close the class. Mrs. Kushi?
Yeah, it was an
Yes.
excellent presentation.
Yes,
Yeah.
ma'am. We can. Oh,
Yeah.
sorry, sir. Yeah.
So I think the discussion part was also very good. Thank you, Dr. Kushwaha, for an excellent
Thank you.
presentation and discussing the difficult part of bleeding manifestations very clearly.
Thank you.
Okay. Yeah.
Yeah,
Thank
I
you.
can see one question which has come up now. The bleeding assessment tool scoring, is it available? It's easily available on the website. On the website, Dr. Malika is asking this question, and it can be definitely, you can take a printout and keep it in the your labs. It's easily available on the website. You just have to put ISDH SSC bleeding assessment tool.
Okay. So we can conclude the session, I think. Yeah.
Thank you so much.
Thank you.
Thank you,
Thank you.
sir.
Thank you, ma'am. Thank you, sir.
Thank you.
And good night, everyone.